anybody want to say anything whilst we wait for another few people to arrive?
I'm happy to say something.
Yes, I'm listening.
Hi, thank you. I'm really interested. I'm a student at the Karuna Institute, and that's a relational model, mindfulness-based core process psychotherapy. So I'm really interested in hearing more about your work and your approach, because it seems very similar.
Yeah. Well, we're certainly using similar words, but we don't always mean the same thing with them. Yeah. So one of the workshops that I've been running for some years has the title, "What do we mean by relational?" Yeah. Because when you dig into what people really have in mind when they're using that phrase, it turns out they are talking about quite different experiences and quite different principles. We might just say at this point that the idea of the relational is not actually that very old. It's only 20, 25 years that it has been a recognizable description, that people identify with. And these days, of course, like with psychotherapy integration, like when I first started, everybody was in a particular approach. And, in a group like this, you would ask at the beginning, say a little bit about your training, your background, your work. And then people would say, I'm person-centered, I'm Gestalt, I'm psychodynamic. And people clearly identified with these traditional approaches. These days, if you ask the same question, I'm integrative. So there's been a movement since the early 90s from quite clearly defined approaches to the idea of everybody being integrative. So then being integrative loses some of its meaning, because if everybody is it, then what does it actually, what are we talking about? And a similar thing has happened with being relational. And you find really quite different and opposite principles all claiming for themselves that they are relational. So we really need to dig down a little and investigate, what do people have in mind? So that's in a way the starting point for tonight's topic, that we can recognize two identifiable extremes of relational positions that have had a long-standing argument, decades of arguments. I'm most familiar with it in the UK, but I know it's gone all over the world. The extreme positions are quite easy to identify. So let's remember that Freud, when he started, he had no doubt in his mind that what he was doing was a medical treatment. He thought of himself as a doctor for the psyche. So that means he was the doctor for the body. He wasn't a doctor just for the mind, but he thought of the psyche as this third realm between the body and the mind. He thought that maybe eventually everything might be reducible to neurology, i.e. to the body and anatomy. But at the time, he was working hard to keep open the psyche as a third space, not collapsing it into the body, not collapsing it into the mind. But he had no doubt that he was operating like a doctor. And what does a doctor do? A doctor does kind of examination, then they do a diagnosis, and then on the basis of that diagnosis, they prescribe a treatment and administer a treatment. And Freud had no doubt that all of that would neatly apply to this new realm that he was dedicating himself to, the psyche and psychological pathology. So it's only belatedly, within psychoanalysis, there were early murmurs and wonderings and critiques, and there were arguments about this, but there wasn't really a serious questioning of the medical model as the dominant framework for our work until later in the 20th century. And a lot of that really came to the fore only with the humanistic revolution in the 1960s. There were earlier critiques and challenges, but a full-fledged questioning didn't really happen until the humanistic revolution. We have to remember that historically there was a phase in between psychoanalysis, where psychoanalysis was the dominant force in dealing with the psyche for some decades at the beginning of the 20th century. But then in between there was behaviorism. And behaviorism also very clearly was operating within a medical model assumption that it was a treatment. And there was a clear technique, and it was quite opposed to psychoanalysis, but it was clearly a treatment and conceived of as a treatment. And still to this day, behaviorism, cognitive behavioral approaches operate largely, I mean, these days everything is mixed, and like I say, everything gets integrative, and so the distinctions get a bit fudged, but predominantly we can say that cognitive behavioral therapists operate within some kind of treatment paradigm, as do other modern approaches like EMDR or other approaches. They think of themselves as medical procedures with a diagnosis, with an examination, investigation, diagnosis, and a treatment protocol, in which the patient, in that model, in that paradigm, we're thinking of the person in front of us as a patient, where we apply a treatment to the patient based on our theory. So the patient is a case, a particular case in front of us is an instance of our general theory about how human beings might be psychologically healthy or unhealthy, and what goes wrong with them, and what's the pathology, and how can we do therapy to correct the pathology. So all of that can quite happily occur within a relational framework where the therapist thinks of themselves as a doctor for the feelings, or let's say for the feelings and the mind. And the patient also thinks of it like that. And of course, some of that can be deeply helpful. When we are making these distinctions and we are thinking about the different relational positions, we do not have to fall into the polarizing trap of the argument, the way it has been conducted for many decades, which is that one side is totally right and therapeutic, and the other side is totally wrong and counter-therapeutic. So I'm not talking from those polarized assumptions, but we do need to make the distinctions. So the beginning of there being a distinction and an explicit contradiction really starts with the humanistic revolution in the 60s, where people argued that what works in therapy is not some kind of expert doctor delivering a treatment, but that what essentially works in therapy, in the kind of therapeutic relationship, is a meeting between two humans. And usually we use the word authentic. We can use other words for this. Other people since then, especially in Gestalt, have used the term dialogical. That there's a dialogue between client and therapist, and it's the nature of that dialogue that really ultimately has a therapeutic effect on the client. Or with Carl Rogers and the person-centered approach, we can say that it is the authentic meeting, person-to-person meeting between the client and the therapist brings to it, as Carl Rogers defined, what he called the core conditions, i.e. empathy, unconditional positive regard, and congruence. And it's especially the third item of congruence that makes the therapist a real human being in the therapeutic encounter. Because if the therapist, congruence means that I am, all the bits and pieces of me are congruent. I don't split myself into a role that I deliver to the client and some person at the back of the role, which is who I really am. On the surface, in most simple terms, we can say that congruence means the role and the person of the therapist are congruent. And that implies that the person of the therapist is really present and validly present, and not just validly present, but in the humanistic argument against the medical model, that is the deep foundation for what makes therapy work. The capacity of the therapist to engage in an authentic human encounter. Does that make sense? So these two extremes of the argument, the polarized positions, they were fairly entrenched for many decades. So when I became a therapist in the 80s, I'm not quite old enough to have been around in the 60s. So I came to it in the 80s, late 70s, early 80s. And during out all that time, 80s into the 90s, certainly within the UK, which is the place that I know best, that I know how counseling and psychotherapy historically evolved, especially in the UK. And in the main journals, like at the time, the British Association for Counseling, there was an ongoing argument for years. People contributed different perspectives and different contributions, but the argument was basically going on in an unresolved, polarized way, where the humanistic people were saying, if you take a kind of expert position that treats the patient as an object, that's what they've had all their lives. How can you imagine that, telling them who they are and what to do and taking an expert position, that has any helpful effect when that's how they've been treated all their life? There's one more authority coming along and telling them who to be and what to do and what not to do and how they're pathological and what's wrong with them. How can that possibly be therapeutic? That's the humanistic argument against the medical model. Does that make sense to you? So they're saying it's, for most human beings, it is profoundly unhelpful to be treated like a case by a professional, even if the professional is an expert, but ultimately people feel that being treated like a laboratory rat, that they are, a case and an object. What people really need, if you want proper therapy to happen, that's how the humanistic therapies argue, then you need to encounter them person to person, as one subject, human subject, to another human subject. That can have a profound transformative effect when the person gets taken seriously as the subject, as the person they are. And they feel that you're empathic with them and that you can regard them without judgment and unconditionally, that you value them. That is what people really need in order for therapy to happen and for therapy to get going. That's the humanistic argument. Then in response, what does the medical model proponent on the other side of the polarity, how do they argue back? Does anybody want to give me a kind of idea? What does the medical model person say in response to that humanistic challenge? Just think about it for yourself. If you were a proponent of the medical model and you felt, well, the humanistic argument maybe has some merit, but that's not the whole story. What would you say? How would you champion the medical model as a valid relational position in psychotherapy or in counseling? More difficult, huh? The humanistic argument I've already declared, so that's not so difficult to argue. But for most of you to validate the medical model is a more difficult argument. So give it a shot. How would you argue for the medical model?
Well, I would say that if people need that kind of connection, they can use their friends or their family or a priest. But when they come to me with a problem, I have studied this, and I am ready and equipped to help them. So they need to listen to me because I know.
Mhm.
Yes.
Mm. Yes, I can expand this a little. So most of the time, many clients and patients will exactly argue like that. They say, you're the expert. I've got a psychological problem. I don't know anything about psychology. I'm just having a problem. I feel helpless. I wouldn't be coming to you if I felt any kind of understanding or agency in this. And I put myself into your hands. Like when I have a heart problem, I go to a heart specialist. I have a psychological problem, I go to a psychological specialist. And I'm hoping that you will offer me your expertise and tell me what's wrong with me and tell me how to fix it. And that's what I pay you for. What on earth would I be paying for if you're just another human being who is kind of being nice to me? I'm paying for expert treatment. I want some value for my money. And how does it help me if you empathize with me? That doesn't make my problem disappear. So going down that argument a little bit further, a more sophisticated championing of the medical model would say, one of the realities that we are meeting, even as humanistic practitioners, and many of you will be able to remember this and confirm this, you may be offering a humanistic presence, let's say a person-centered presence, but the client says, can you fix me? I have sleepless night after sleepless night. I don't want you to empathize with me, having insomnia. I want you to fix it. Can you fix it? So as therapists, we cannot completely avoid the medical model because it's in the client's or in the patient's mind. That's what they're coming for. So even if you completely believe the humanistic argument, the client doesn't believe it. And if one of the main principles of our profession is to meet the client where they are. At some point, we could talk about that. That's actually a much more complicated thing than it sounds on the surface, because where are they really? We could talk about that, but just at its superficial level, we want to meet the client where they are, and many clients want to be fixed. Beyond that, a more sophisticated championing of the medical model would say, the client is coming to me, like as Nassos was already going down that avenue, because they feel helpless. And they do not object, as the humanistic challenge would maintain, they do not object to being an object because they objectify themselves. They do not object to being pathologized because they pathologize themselves. So instead of trying to pretend that that pathologizing and objectification can be healed or counteracted by the core conditions and a nice humanistic stance, a deep championing of the medical model would say, but that doesn't get to the roots of things. That doesn't get to the problem inside the person, that they invalidate themselves, that they pathologize themselves, that they objectify themselves. You can provide a nice therapeutic environment to somebody like that, but that doesn't get to the root of the problem that's already in there. Another version of that kind of argument, in the polarization that has been going on over decades, the humanistic position has mainly been that we want to make client and therapist as equal as possible, because we do not like the power differential of the medical model. It makes people feel small. It makes them look up to an expert. We want to empower people. So we will, as humanistic therapists, we will position ourselves in such a way that it maximizes the empowerment and minimizes the disempowerment of therapy. So we are interested in working towards some kind of equality. Sometimes that goes as far as the humanistic principle that the best expert on the client is the client themselves. Now, many clients will not agree with that, but that is one of the humanistic principles. So that's like the humanistic therapist trying their best, bending over backwards to avoid the expert position. Whether the client feels that they are an expert on themselves or not, there is, at least in the origins of the humanistic tradition, there is a strong attempt to minimize authority, to minimize expert stance, and to make the relationship as equal as possible. Which is, if you think back to the 60s, that was a very precious thing to try and do. In the 60s, after decades of psychoanalysis and behaviorism, you know, when as a client you went to a psychologist or some kind of psychotherapist, you really were mainly getting a kind of power trip. And that's, of course, why the humanistic therapists, the founding fathers of the humanistic traditions, they were all in therapy themselves. And they hated the position that their therapists were taking, because their therapists were psychoanalysts and behaviorists. And they hated it. They didn't feel validated. They felt like they were treated like a case, and they rebelled against it. And they said, I'm not going to do this patriarchal, old-fashioned, authoritative therapy. I'm going to offer my clients a space of equality where a human encounter, authentic human encounter, can happen. But then, of course, the medical model people, especially not so much the medical model people generally, but more the psychoanalysts who conceived of themselves more in the medical position, they would have a very strong argument, you know, as the argument rages back and forth, by saying, if as a humanistic therapist, you set up a relational space that is prioritizing equality between client and therapist, you know, is emphasizing the human equality between client and therapist as two humans, you really fail to recognize that most people's suffering, most people's psychological pain is rooted in their childhood, and that the relationship dynamics that wounded them, that injured them, that messed them up, were relationships of profound inequality. How does a child get to be messed up? It's not just that they're in difficult family scenarios. No, it's that they are the child with little power and very unequal in the family dynamic. So the medical model treatment psychoanalysts would say, if you want to get to the roots of most people's psychological problems, you have to go back in their development to a time when they were very powerless and they were experiencing profound inequality. Now, if you make therapy a space where inequality is taboo, where you've kind of structured it out as a possibility, then how are you going to get to the inequality roots of their psychological problems and their biography? You're not actually helping to heal the deep pain of the inequality and the injuries that come from that inequality. You're just helping them to avoid it by all this emphasizing of equality. See, that's a strong argument. That's not a superficial argument. Or we give the clients what they need because the client pays money to get fixed, and so we propose to fix them. That's a more superficial argument. But this more childhood development, developmental psychoanalytic argument against humanistic equality, that's a powerful argument. Do you have any comments to that or reaction? Does that make sense what I'm saying?
Would there also be
Helen,
an argument there, Michael? Sorry to interrupt.
yeah,
How
go on.
much-
No, it's not interrupting. This is amplifying. This is expanding what I'm saying, probably. Yes,
Thank
go
you.
on.
Yeah, I was just wondering, I was half expecting you to say that the medical model argument against that might be because people have come from that background, then they're not actually not able to participate even in an equal to equal
Yes,
relationship.
yes.
They don't
Well,
have the capacity for it.
Don't you think that's true?
Don't I think it's true? It's in my experience that it can be true. Yeah, but I guess that's what we're trying to
Yes.
trying to help people participate and to help people change that. Yeah. Then.
Yeah, I know, but I think your question is very to the point and very clear. So let's say as a humanistic therapist, which is mainly where you are located yourself doing the Karuna training, there's all kinds of specifics to the Karuna training, about the Buddhist framework and so on. But there's no doubt in anybody's mind that it is squarely located in the humanistic tradition. So whatever side of the argument, traditional argument, you yourself may be thinking about as belonging to that tradition, you inherit a position. You inherit a polarized position. And that's maybe one thing that tonight we can kind of soften a little, that we can see from this, we can see the issue from both sides, which is what we're just right now doing. So let's say as a humanistic therapist, you believe in the humanistic principles, you work towards a meeting of equals, the client is the best expert on the client, and you invite them into an empowered position. And that's the principles of the relational space that you offer. You walk into the therapy room, and that's the kind of atmosphere that you assume as a foundation. So there are two possibilities now at the extremes. One is that the client will be relieved to come into a therapeutic space where that is the therapist's baseline. And maybe they will, like a kind of flower that hasn't been watered for 3 weeks, they will kind of, and they will, breathe a sigh of relief, and they will flourish. They will expand into the space that you're offering. That's one possibility. The other possibility is what you were just saying, that however much you offer it, the client is not actually taking it. So then people say you can lead a horse to water, but you can't make it drink. So why doesn't the bloody horse drink? Well, because it's screwed up. It really has a psychological problem. Even if the horse is offered freedom, it doesn't take freedom. Even if the horse is offered empowerment, it doesn't seem to take it. Even if the horse is in a prison and you open the door wide, does the horse leave the prison through the wide open door? No, it doesn't. So we need to take that experience into account that you're talking about. And we want to understand why sometimes the client responds to the invitation or is able to respond to the invitation, and other times they are not. And other times when you give that humanistic space and invitation, they even attack you, or they dismiss you. Like we were just imagining, they might say, well, but how is that going to help me? That doesn't fix me. I've already been working, beavering away at trying to solve this problem by myself for years. And now you come and tell me that I'm the best expert on my problem. Well, bollocks to that. Good. You see, that argument has been raging for many years. And probably in Greece, there have been different permutations of that. Those of you who have studied recently may not have experienced the full brunt of the polarization, because what you more likely have experienced is an integrative fudge, that you do a little bit of both. And in some situations, you operate as if you are an accountable doctor expert. And in other situations, given half a chance, when the horse does seem to drink the water, you operate like a humanistic therapist. And so you can fudge the whole thing. You do not have to be, banging your head trapped within this polarization that's been going on for years because you have the benefit of coming late to the party. So maybe this thing isn't even that kind of relevant to you, or you don't quite see why I'm going on about it or why I'm passionate about it. But you have to take into account that I spent years of my adulthood, years of my career with people kind of head banging from both sides, arguing the toss and trying to convince me that the other side was categorically, therapeutically wrong and a bad influence. So it's taken me some years to say, well, look, there must be validity in both of them. There must be some way that we can square the circle and integrate those polarized positions in the argument. And I started saying that kind of thing, probably in the sort of early 90s, mid 90s. And I ran workshops on entitled Embracing the Paradigm Clash Between the Medical Model and Counseling. So rather than having the paradigm clash and feeling all confused and split and torn in half by it, I was thinking about how can we embrace the clash? How can we do justice to the validity of both sides of the argument? Because that's like a bad marriage. Huh? The whole field is a bit like a bad marriage. People are bickering and invalidating the other at every turn, and nobody constructively agreeing on anything. In wise anticipation of this whole topic, this is something that like a series of slides that I've been thinking about for, I don't know, 20 years. So I'm accepting the starting point for these slides is that I'm accepting that this polarization has been going on historically and that it is a meaningful argument, that there is a rhyme and a reason and a purpose to it. So in what language can we talk about this? I think a good formulation is what you can see on the screen now. I'm not quite talking about treatment, and I'm not quite talking about a humanistic meeting of equals. I'm more at the very top, you can see, I think a better way of also in terms of getting really into the meaningfulness of the polarization and to get to extract some kind of juice from it ultimately. It's better to say that there is an opposition between therapy being a space of authority, where the client or the patient comes to an authority and comes into the space of that authority, versus it being a space for joint exploration. If we can get beyond the two sides decimating and annihilating each other, we can think about each of these positions as having some essential, profound therapeutic validity. So what would be deeply therapeutic? I've already talked about this in its origins and how the humanistic therapists argued. There is something valid about the humanistic argument. So what is that? We could say that the idea of being an equal, a human equal, that can be powerfully helpful through authentic relating as a person. That can happen. I can see there on the left, in the middle of the left column in red. What the humanistic therapists from within the traditional polarized position cannot quite appreciate is that many clients and many patients feel that they are being helped and that they have been helped profoundly and genuinely by an authority that is operating from within and through a role, like an expert role. So in lived reality of clients, if you ask clients and you do a survey, they will say they find all kinds of things helpful. And many of them will say that the authoritative presence and input from the expert has really, really helped them. and they found that therapeutic. But then you can equally find a good number of people who said, well, what was really the most therapeutic thing about this therapy was that the therapist was so genuine, and he was a real human being, and he was, you know, full with emotional presence and genuine care. And the powerful thing about the therapy was that authentic relating, or the authentic presence, at least, of the person. So we can extrapolate at the bottom. Now I'm coming here to the bottom. Can you see my mouse moving there? So at the bottom, if we put some abstract words to it, we can say there is the validity of the humanistic position, or what the humanistic position championed is the validity in therapy of dialogical person-to-person relating. So in the time of Carl Rogers, people were talking based on Martin Buber about the I-thou relating, and that the therapist sets up this kind of space of I-thou relating. Later people have, because the thou has a bit of a kind of religious connotation, which some people, secular people, didn't like, so they changed it to I relating. Or if you want to put even other labels and words on it, more maybe recent, that would, people would talk about subject to subject relating, or intersubjective relating. So Karen, when you said what, you know, when you and I talked about what do people mean by relating, so one meaning of being relational that gets attributed to the term is intersubjective meeting. And in relational psychoanalysis, which is a modern form of psychoanalysis that has developed way beyond the treatment history of classical psychoanalysis, they would say that what really works about therapy is what they call mutual recognition. And that's another word for what we can describe as dialogical person-to-person I relating. So some of that we could assume, because some people have argued it so passionately, and they've built whole kind of therapeutic systems around it, and it seems to be working for some people some of the time, there must be some validity to this. That an essential pillar, an essential foundation of therapy is authentic person-to-person relating. And that would be one meaning of being relational. But equally, on the other polarity, on the other side, we could abstract the validity into saying that an essential element to much therapy being helpful and therapeutic is that there are different varieties of authority positions. So that includes treatment, or we could also talk about something, a distinction introduced by somebody called Martha Stark, where she talks about this as one-person psychology. You see, in one-person psychology, some of you may be familiar with the term, it is only the client's or the patient's psychology that gets looked at. Here, on the other side, on the humanistic end, it is already implied and understood that both people's subjectivity, i.e. both people's, the client's and the therapist's psychology, are co-creating the space and are relevant. So if things go wrong significantly between two people, it is not just the client's fault. In this paradigm, the red paradigm on the left, we would have to look at two psychologies and what they are contributing to a problem, or let's say a rupture in the relationship, if it quotes goes wrong. In the traditional blue paradigm here, in one-person psychology, if something goes wrong, traditionally it would be considered the client's fault, the client's problem, because the authority is supposed to be a neutral, benign doctor who's doing their best to help the person. So if the client doesn't like it, it must be their problem. Okay? And as I said, the treatment implies a kind of objectification. And so instead of I relating, we would call that I-it relating. if we transcend the polarization, we can say that there are some therapeutic relationships, some therapeutic contexts, some aspects of the therapeutic process where that is validly, the whole blue side is validly experienced as helpful and therapeutic. Okay, we haven't got that much more time of me talking, so I'll speed up a little. So what that means for me, as I said, I encountered this polarization, in the late 80s, early 90s, and I started arguing that there must be a third position that embraces both, which is why I put the infinity sign there in the middle. That means if you validate both when all around you these two positions are at loggerheads, that must be because you are able to hold an ambiguous, contradictory, conflicted, or paradoxical position, where you're not lost in some kind of Aristotelian logic, where A and B, if they're opposites, can never be true at the same time. I've got some news for Aristotle, because in the field of emotion, two opposite emotions are true most of the time. So in the field of psychology, as opposed to the field of maths, two opposite truths can perfectly, validly, and productively coexist. And that's obviously what I've been trying to do for the last 30 years in respect to this polarized argument. So that means, as you can see here, that as a person and as a therapist, I think it's very valuable if I can take a position and if I can create a space around myself where I can endure and embrace the tension between the polarities, because they have got truth and validity about each of them. One thing, if you want to hold a position like that, a third position, or you might say an integrative position, or you might say a paradoxical position, because, most out there in the world, people on the whole think that you can't hold on to two opposing truths, mutually exclusive truths at the same time. Well, humanly, it's perfectly possible. Some of you may have come across a poem by Walt Whitman where he says, he gets challenged and he said, I contradict myself? Yes, I do contradict myself. Very well then, I contradict myself. I contain multitudes. So that's a validation of that third position, where two opposite truths can be perfectly coexisting at the same time, which requires, as it says at the bottom here, that I need to be able to surrender to being in conflict rather than be some kind of consistent, apparently consistent only half of me. Okay. So I've been trying to inquire into this third position for the last 30 years. And as I've hinted at in the description for the evening, the more you do that, the more you find out that within the apparent polarity, where there's only, night and day, right and wrong of one or the other, you find out that inside the polarization, there's actually a variety of positions. There's a spectrum rather than a polarity. But first, as an intermediate step, so there's many slides, but I'll show you the next two. Holding that paradoxical position means that you can see the profound value of each, but also the profound fallacy or folly of each. Yeah? So, as we already hinted at earlier, there can be something profoundly valid about the humanistic position, which is that there is a kind of power, that the client experiences a kind of power with empowerment through the shared humanity. But it's also possible, and many clients will, when their therapy has finished or broken down, they will tell you in no uncertain terms that they found their humanistic therapist to be a useless, disappointing equal, or that they found their humanistic therapist to be collusive or useless. I've been involved in an assessment and referral service where people come to me and say, help me find the right therapist for me. And I've been doing that for many years. And very often you get clients who have been in previous counseling and therapy, and they will tell you what their conclusion was. I'm not saying their conclusion was right or valid or that everything they complain about was exactly the case. You need to take all that with a pinch of salt, but you certainly hear some kind of unpalatable, difficult truths about how the general public experiences their therapy. They feel quite free to, if you invite them, they feel quite free to speak about it in very unfavorable terms. So from that, it becomes very obvious that the downside of the humanistic space, the humanistic tradition, can be that it is quite disappointing to some clients some of the time. And equally, there is the downside or the shadow side or the disadvantage of the authoritative and expert position here on the right, where, at least from the client's perspective and experience, that kind of light blue possibility of being a benign expert degenerates into a negative authority, which was exactly what the humanistic position, of course, was attacking all those years ago. They're saying, well, if the therapist takes a power position, an authority position, then it's quite possible and maybe even likely that they become another negative authority that is not empathic, not attuned, that is damaging ultimately. So if we want to validate both of the polarized positions, we partly do that because we can validate also their criticism of each other, which means that we validate that they each have a shadow aspect or a negative side or a damaging side in therapy. Once this is part of inhabiting the paradoxical third position, that you validate both sides, but you also see the real dangers of both sides. This is just another version of the same thing. So this is the slide I want to get to. There's different avenues into that, but because I haven't got much time, I'll really keep it quite snappy and condensed now. When you really, from that third position, investigate what happens in that ambiguous kind of purple space in between, you find that there are different relational roles or different relational possibilities, or some people talk about then modalities. There are relational modalities of therapy that are hiding within the polarization. And the person who's most known, reputed for opening up that whole spectrum is an English elder of psychotherapy called Petrushka Clarkson, who wrote a paper in 1991 called A Multiplicity of Relational Modalities. What did she mean? One powerful idea she had was that rather than distinguishing the whole field of psychotherapy, in broad brushstrokes into psychoanalysis, behaviorism, humanistic, and then you subdivide them and you end up with, I think these days, about 400, 500 therapeutic approaches with all their own trainings, their own schools, their different theories and techniques. And you wonder how any rational human being and member of the general public ever chooses their therapist in that kind of confusing mass of everything, this bazaar of all these approaches. If they want to go, if they have a heart problem, they want to go to a heart specialist, they don't have to choose from 500 different approaches. So to a member of the general public, this division, this fragmentation of the field is utterly off-putting and mad. But Petrushka Clarkson said that underneath all of that diversity, we can find different relational modalities, or I would prefer maybe to say relational spaces, which exist across all the different therapeutic approaches that have similarities or that are similar to different family members in an extended family. So she called that kinship metaphors. So in an extended family, traditional family, long before the nuclear family, in an extended family, you have many kinds of loving, many kinds of attachment, many kinds of support, many influences, relational influences. You've got grandparents, you've got aunts and uncles, you've got cousins, you've got this whole mixture of different ages and different relational positions, and therefore different relational spaces, and therefore different kinds of love that occur in these different relationships, and different kinds of help and support and relational benefit that you can derive from these different family members and their different position in relation to you. So that's a powerful idea, that psychotherapy, the field of psychotherapy, could be compared to an extended family, and that different psychotherapists take a stance or take a relational position in relation to the client that resembles those traditional positions in an extended family. Does that make any sense? Have you come across that? Is that a new idea? So if you run with Petrushka's suggestion, then the polarity breaks down into this whole spectrum, that you can see on the screen now. I've put in a few other terms that are not part of the extended family, but they are part of the, let's say, certainly a child's fantasy of an extended family, because you can see there's a fairy godparent in there and so on. So there are all of these different relational positions across the spectrum. And when I talk about being relational, I've come to the perspective that I'm talking about a fluidity in the therapist, the capacity in the therapist to be moving fluidly between them. So that means I need to be able to see the point, the therapeutic validity of each of them. And I need to find a way of making myself available, if that is what may be needed by the client. I need to be able to make myself available in that kind of stance or position or role. And of course, that's not fixed. It's a constantly fluidly changing, dynamic, evolving process. But you can see how this offers us many more options for the kind of position we might be taking than just the polarized extremes. There's lots more that we could say about that, and what I'm saying now about the fluidity, the therapist's flexibility across the whole spectrum, that's not quite the whole story. We need to qualify that, and there's things, it gets more complicated than that. But for now, as a kind of introduction and a kind of rounding off to this initial presentation, I think I've said enough. And so maybe first you can have some questions, clarifying questions, and then we can have some space for question and answers and discussion. So I'll leave it here. Maybe I'll leave this on screen for a while, but maybe we could start talking about it, and you can come in and ask questions and try and clarify things or comment, or how this makes sense or it doesn't make sense, or what it's missing. Please feel free to come in.
Okay, Elias has written a question I'm going to read. He says, are we really equal, therapist and patient, if the therapist holds more knowledge of the psyche?
Yes, exactly. That is one deep, valid element of the blue position. That's not the whole truth, but in some situations, it's the bulk of the truth. Now, if we are really finicky from the humanistic position, you could say, well, is the therapist an expert on psychology? Or are they really, when we look into it, mainly an expert on their own psychology? You know, they've been in therapy, they've explored their inner world, so they've become knowledgeable about, it's like visiting a different country, isn't it? Out there in the world, many people live their lives without ever being particularly interested or introspecting into their inner world. To them, the feelings arise, and that's all fairly matter of fact, and they try and cope with them and manage them as best as possible. But there are many people who live their lives not being particularly interested in what goes on for them, or what their inner world says, or what their fantasies are, or where the feelings come from, and how they relate to themselves, and that a different kind of way of being may be possible, and maybe they you know, they think, oh, you know, this is who I am. A leopard never changes their spots, and I just have to live with this. Whereas some of us who've been into therapy, we could say, yes, we have become experts at our own internal world, because we understand how it has grown, and we understand that it can change, and we can understand that it wants to change. You know, it's like nothing is stuck or permanent in the universe. The psyche, the inner world is evolving. And so we could legitimately claim that I have become more of an expert, at least more than average, in my psyche. Whether that automatically makes me an expert in somebody else's psyche, that could be questioned. From the humanistic position, you know, the other person is really other. And being an expert on my own psyche doesn't automatically make me an expert at your psyche. That would be the humanistic counter argument, but we can, you know, like I say, we can be finicky and be, you know, trying to be precise, but generally speaking, yes, that is a valid argument in the mind of most clients. They don't feel they're an expert. They feel helpless. They feel lost. They feel at the mercy of things. You know, whatever issues bring them to therapy, they don't feel they have agency. They don't feel they understand. They don't feel they're an expert. They feel lost, and they want, and this is of course the foundation of some kind of transference, that if I'm a client who feels helpless and lost, and I don't know whether I'm coming or going, and this problem has been with me and nothing that I've done has made fundamental difference, I want to go to an expert, to a doctor. But that, of course, is the beginning of a kind of parental transference, where I'm looking up to the therapist as a kind of parental figure. And I feel more in a child position. You know, I'm new to this. I feel small in this. I don't understand this. I mean, this reminds us of this puts us more close to a child position and puts the therapist more into a parent position. And that can be a very valid starting point, and from that can start a very valid healing process. Many of you, you know, who have been in therapy, you will remember, you know, not maybe everybody, but for many of you, all of that, to have the therapist be an expert, and beyond an expert, a kind of parental, benign figure, a nurturing, understanding, curious, interested, supportive, having your back kind of parental figure, maybe unlike the one that you actually had as a child, that can be a profoundly beneficial, therapeutic, helpful, wonderful experience. Many people who come out of therapy and say, that was the best thing I've ever done. I feel so much better in myself, in life. I feel so much more able to cope with life on the back of that therapy. They will talk about their therapy as if it was a kind of substitute parent, as if the therapist had done a parenting job, a reparenting job, where maybe the first parenting had been lacking. So yes, that is the totally valid position. Does that answer your question, Elias? I didn't actually even see it, so I'm not quite sure where the question is.
It doesn't have a mic, so now.
All right, okay. So you're reading on his behalf, yeah.
So he says, so that would somehow destroy our science, that actually we have no knowledge at all beyond our psychology.
That would be what some, we might say, extreme people from the red end, from the humanistic end, that's what they would argue. Yes, there are humanistic therapists. I'm thinking, well, I can, they tend to belong to particular therapeutic approaches. So the people who are most hot on this, most critical of the medical model, most questioning of science would be modern Gestalt therapists, modern existential therapists, modern narrative therapists. These would be some of the top approaches where that kind of what you might think of as an extreme critique, being far on the red side, and critiquing, and maybe you could say making bad the blue side altogether. But there are people who argue like that, yes, and they would say it's not a science. There's nothing scientific about therapy. There is just human narratives and human attempts to make sense of a confusing world, and we can only do that together, as equals. That's what they would argue, and they would question any attempt by any therapist to take an expert position. Yes, they would. Maybe it doesn't make sense to you, but it certainly makes sense to them. It's good for us to know that there are people taking these, what you might consider an extreme position, but these extreme positions are precious because they help us clarify what the argument really is. So you could say, well, they're extreme, and that's not a position I want to take. I want to take the purple position, sort of integratively in the middle. But you can still be grateful to the people who take the extreme position because they help to clarify what the deep substance of the argument actually is.
So the last comment, he says, so these psychologists actually declare that they are not psychologists and their studies and occupation is not valid.
You could say it like that. I mean, it's an ironic way of putting it, but yes, I think you would have a point, because they would say it's not a scientific position, it's not a medical position, it's just a human position. And as we already said, they might struggle a little to justify why they're taking money for it. No, they obviously will try to square the circle and argue the toss that, there is some asymmetry, but they would struggle to answer it clearly, I think, in my judgment. But they, of course, would argue that they're entirely coherent and consistent. So, but as I say, there is to all of us, there is a preciousness that comes from some of us taking an extreme position. But of course, what's really relevant to this is what Karen already said earlier, that let's say I'm wanting to take one of like a more extreme position, which is also a very congruent position. The client walks through the door and I'm just refusing categorically and declining to take an expert position. And we already said some clients might find that such a relief to be not talked down to not be kind of pathologized, that some clients just will not recognize that as therapy, and they will just walk. They will just, not engage. And in a way, if you take a more one-sided position, that's fine, because, you know, maybe it's totally valid for, if you take that position, you attract and you end up working only with people who are up for it, you know, like where the horse comes to the water and then actually drinks. So then you say, I don't do scientific expert therapy. I offer a space for joint exploration, as it says at the top. I offer a dialogical space. Please, if you want that, if you're up for that, if you see the point of that, if you're ready for that, then come to me, and we can do this kind of therapy. And so there is total validity in, you know, the therapist then practicing what it says on the tin. In English, we have that saying, you know, you're selling exactly, you know, you're describing what is in the tin and you're selling what's in the tin. So that's totally valid. It's not what I would want to do myself, because I want to be able to, to me, it's a valuable thing to be able to meet a wide variety of clients in their idea of what therapy is. And some of them want to be fixed. And if I took a more one-sided position that therapy, I'm only going to practice therapy as a space for joint exploration. I will not be an expert. I will not be seduced into being an expert. I will not give answers. I will not give diagnoses. I will not pretend that I know better. I won't offer any of that. That would exclude a good chunk of potential clients, which, as I say, is a valid thing to do. But I personally don't want to do that. I think there's something precious about the whole being available to and inviting the whole diversity of human experience, and to meet everybody where they are in their subjective reality. And if somebody wants fixing and they're signing up for treatment, then treatment is on the menu. If they're signing up and if they come because they've you know, researched all of this, and they say, I understand that some people interpret the meaning of relational to be a space of two humans jointly exploring one person's psyche, and that's what I want to pay you for. I basically pay you for that kind of relationship. I think that's great. Let's have that kind of relationship. I can say one more thing to that. Why do I prefer this more integrative position that values diversity? Because ultimately, I believe that there is diversity in the client's inner world, that there is diversity in the psyche. I want to be able to be an integrative therapist that can range across the whole spectrum, because ultimately, I think the client's sense of being a whole human being depends upon them being able to range across their internal spectrum and to have all the human possibilities available and accessible. So I think the more diversity there is in the inner world, the more whole a person feels. And that's why I want to meet the internal diversity in the client's psyche with an external diversity of different relational responses and spaces and therapeutic possibilities. Shall I stop sharing the slide now so we can go back to conversation? Do you have it in mind? Do you have, is it present in your mind so I can take it off the screen? Okay, I'll just stop. Okay. I can send you the slides after the session. I'll send them to Dimitris and then he will pass them on to you.
I was taught that 70% of therapy happens because of the relationship rather than expert knowledge or what kind of therapist you are and things like that. I wonder if you have ever heard of that. I mean, it's the kind of relationship you build with your client rather than, which is exactly what you're saying, but I've heard it like a result of, as a result of studies instead of the way you're presented it, which is great. I'm totally enthusiastic about it. Have you ever heard of that? That 70% of therapy happens because of the relationship you build with the client?
My suspicion is that people come up with these figures from within the polarization. Something completely else can happen when you integrate the polarization. Because the more you refuse to get locked into those extremes of the spectrum, the more you realize that the whole thing is paradoxical. And most of the time when people try to resolve the polarization, well, I said, sometimes people fudge it, and sometimes, a lot of the time, people oscillate. They take this position, they take that position. It's a little bit like a kind of flag flying in the wind, depending on which way the wind blows. But if you understand really that that contradiction is a paradox, and that both are true at the same time, and that both of the polarities actually constitute each other in their contradiction, then what becomes possible is that you can understand this apparent external tension between being an expert and being, you know, being, let's say, an equal, reflects a conflict in the client themselves. Now, the people who put these figures on it, they don't necessarily think that. Also, the problem with how they put the figures on it is, you know, it sounds like it's from within the split, which is what I was trying to address in the early 90s. If from within the split, the humanistic people will argue that the medical model experts and the psychoanalysts are not being relational. They are being relational because they're empathic and blah, 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 and that's a good way of being relational, and that the medical model and the doctors and the psychoanalysts are not being relational. And of course, there is some truth to that, but that's from within the polarization. When you integrate the polarization, the way you can think about the medical model is not like some kind of distant clinician who imposes a treatment upon you, but you can think of the medical model like a family doctor. Maybe in Greece, you still have the memory of a traditional family doctor who probably knew you from when you were born. They probably were there during your pregnancy, and they knew your family, and they were the family doctor, and they were very relational. They were actually more relational than some kind of humanistic people, because they thought systemically, they thought holistically, and they really cared about every member in the family. So a family doctor like that, that's a kind of relational version of the medical model. That's a kind of human making best use of medical model and a medical position. And so there's a lot of love that can come through the traditional family doctor position. So for somebody to say that's not being relational is really to misunderstand the helping, healing, loving potential of the medical model when it is applied, when it is administered through a human being and through a consistent relationship of that doctor to the family. There's all kinds of good aspects to that traditional family doctor. They're thinking systemically, they're thinking holistically, they treat the whole system rather than the individual. There are many wise aspects. And so we want to be, so then you can't say the doctor isn't being relational. It's just a different way of being relational. And this goes back to what Karen said earlier, you know, what do we mean by relational? So from a third position, I would not say, oh, the humanistic person is being relational and the family doctor is not being relational. I would say they are being relational in different ways. And then probably the numbers don't quite, they stop making sense, because the depth of therapy and therapeutic transformation probably depends upon the therapist being able to make use of the paradox. So the more you can be an expert in one moment in the therapy, the more some process happens by which you have a moment of meeting as equals. And that opens up another deeper layer where there is some kind of inequality and some kind of transference. And then you suddenly find yourself in a very unequal space again, where the client constructs you as an authority, and you need to fulfill that role of the authority. So it keeps going back and forth. So from the third position, you see, the whole thing becomes dynamic, where the validity of both positions makes the process go deeper and faster. And then it's important that the therapist can range across the whole spectrum and include the extremes. And then the figures, the meaningfulness of the numbers breaks down, because the 70% depends on the 30%, and the 30% depends on the 70%, and how you do the 70% influences the 30, and vice versa. So then they don't make sense anymore. That's talking from an integrative paradoxical position. And that's quite rare. Not many people, when they make these claims about 30, 70, and so on, not many people can speak from that integrative paradoxical position. Does that make sense? You could say in a more ordinary language that the kind of equality that becomes possible between client and therapist depends upon the degree of inequality that the two of them can survive and allow. The more inequality you can allow as part of our encounter, most of us have deep longings for inequality. We long for some kind of parent. We long for some kind of wise authority. We long for some kind of person who can really hold us and take us in their arms and like an ideal parent. We have deep longings for the other to be unequal. There's a kind of love that arises from being able to surrender to inequality. We all have deep longings for that. That's not a bad thing in and of itself. If you cut that all off, if you legislate against inequality, you cut off a vast area of human experience and human loving. So you want to be able to allow the inequality, and then sometimes, yes, out of that, the more you can allow that, you have magical moments of equality, of intersubjective meeting, or of mutual recognition as subjects, or whatever language you want to wrap around that. But it's not going to happen if you try to manufacture equality. It's more you allow inequality, and you allow the process of inequality to change and transform, and then suddenly equality happens magically for a little bit. That's, to me, that's a wiser formulation.
Is what you say close to what we call authenticity in a therapeutic relationship?
Yeah, I mean, if we look at the different words, concepts, language that the people on the red end of the polarity have been using, yeah, there would be. That's really the essence of what originally was meant by authentic relating. You as a human being, me as a human being, whether we call it I relating, authentic relating, other people call it in Gestalt, they call it dialogical relating. But it is the recognition of you as a person by me as a person, and vice versa. The complex, wounded, flawed subjects that we are. I recognize you in your wholeness, you recognize me in your wholeness, and that's where we meet. That would be authentic relating, yeah.
In authenticity, I may have more knowledge in something and you may have more knowledge in something. So the balance changes. Does it make sense what I'm asking? Expert authorities change all the time.
Yeah, you could say it like that. Or another way of saying it would be that I have ignorance, you have ignorance, and together we discover something better.
So it's a relational thing all the time.
Yeah, from within that paradigm. Yeah, yes.
Yeah, it's on the.
That's why I didn't use the traditional language to characterize it as the headline for the red side of the argument. But that's why I prefer to call it a space. Therapy is a space for joint exploration.
Okay.
So that would be my formulation to really bring out the essence of what other people call authentic relating and why that is therapeutic. It's a discovery. You know, what's important about that space is that, yeah, there is equality, but there is equality in a kind of open, uncertain exploration. It's the discovery, and that's an important aspect of authentic relating. Sometimes you get very modern, narcissistic perversions of what supposedly is authenticity, where, you know, I say things to you like, I don't feel I'm being authentic because I feel you're not meeting my needs. So this relationship is not good, and I'm being authentic with you. No, as far as I'm concerned, you're being an authentic asshole because, you know, you think you know who you are and you sound very certain, and you know, there's nothing particularly authentic, exploratory about your position. You're just, you know, being like a kind of grown-up toddler who's stamping their feet and wants their ice cream. So even if the person says, well, that's authentically who I am and what I'm feeling and that's what I want, that doesn't necessarily qualify for authentic relating. That's just, you know, narcissistic entitlement. And there's a lot of that. You know, there's a lot of authenticity being used, being driven from the inside by narcissistic entitlement. That's why I prefer to call the therapeutic possibility on the red end of the spectrum a space for joint exploration. There's a togetherness in an exploration which comes from not knowing, and not knowing myself fully, and not knowing especially you fully. So the exploration is across in the dialogical uncertainty of the self and other. That's a precious capacity of the human being, which many of us only are capable of manifesting in degrees. But if we can, that makes for powerful therapy. Yes. If you want a turbocharged, fast therapeutic process, that's a good attitude to take. But many people are not quite up for it, or only in degrees. So as Karen was implying earlier, I can come into the therapy room and I can say, okay, as a first port of call, I offer a space for joint exploration. You know, that makes sense to me. That's what I offer. I don't have to be claiming to be an authority or an expert. I don't have to be claiming knowledge. I'm quite happy to sit there and explore with you. Now, if I offer that space, I then have to be awake and alert to the degree to which you're actually making use of it, to which you're responding to that invitation. If I'm inviting you into a joint exploration and you're just declaring your narcissistic entitlement, then I will probably conclude sooner or later that joint exploration is not on the menu, and that there is a deeper cry for help, which probably requires me to be an expert. And then if that's what appears to be needed, then I'll give you that. I'm not invested. I don't have to be an expert. I don't particularly want to be an expert or claim to be an expert. I have no investment in that. But if it's needed, if it appears to be badly needed after several offers and invitations, and the client doesn't seem to be able to use the space for joint exploration, then I'm very happy to be a doctor. And I will be an expert, and I will make pronouncements, and I will, you can hear, I can talk endlessly. I can sound very knowledgeable and wise and certain about all kinds of things. So if the client badly wants me to do that, I quite enjoy hearing myself talk. So I can be a doctor if it's needed. Do I think it's the best way of going about it? Probably not, but it's just another part of the journey. And maybe we need to be in a kind of expert authority doctor space for a while before some kind of mutual exploration becomes possible. So we do expert therapy for a while, and then maybe we do later joint exploration therapy for a while, and then we go back and forth, and the process deepens. That's fine by me. I can get excited about that kind of process. And I feel it has the potential to really do justice to meeting the client where they are. Because the client, I'm not thinking of the client and where they are as one static place. They keep changing, they're impermanent, different things come out. And so I want to be able to fluidly and flexibly respond to where the client is at any point in time, because where they are is a moving position. It's a moving target. And I want to be able to meet them as they are changing in where they are. So thank you very much, everybody, for paying so wonderful attention.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you very
Bye.
much.
Καλό βράδυ.
Καλό βράδυ.